Sir, we are live now. Sir, with all your
Yeah,
permission, sir, I'm starting this session for today.
yeah.
Good evening, everyone present here. I am Faraz from IJCP Group. Welcome all the participants to today's session. Let's welcome today's speaker with great honor, none other than Dr. P. Karthikeyan, sir. And let me share some of the achievement of sir. Sir has done MD in internal medicine, DM in gastrology, and he is medical gastrology at Royal Care Super Specialty Hospital Limited, Coimbatore. And today, sir is going to discuss on a topic gut microbiota in irritable bowel syndrome, World Irritable Bowel Syndrome Day. By taking not much time, I would like to invite sir and hand over this session to sir. Over to you, sir. Kindly proceed from here.
Thank you. Thank you very much. Thank you for the invitation. I am really happy with that. So so let us go to the topic because it's already late. It's late. So being a irritable bowel syndrome day. Previous slide, please. Please start. Yeah, first slide. Okay. Okay. So this day for yesterday was irritable bowel syndrome day. So, in commemoration with the day, so we are discussing about the link between the irritable bowel syndrome and the gut microbiome. So, this has been a hot topic in gastroenterology and for every researcher in the field of medicine and gastroenterology. And there is a potential link between the gut microbiome, the characteristics of gut microbiome, the number of species, the specific species present in the gut microbiome to the symptoms of irritable bowel syndrome. And so much so that we are able to tweak the gut microbiome to have desired results in irritable bowel syndrome. So previously, irritable bowel syndrome was passed on as a psychological disorder, as a disorder of stress, anxiety, etc., with medicine specifically targeted to avoid stress and other things. Now that we have very good evidence that it is not only stress, it is because of the altered microbiome in the gut that may be the cause for predominant symptoms of irritable bowel syndrome. Next slide, please. So this is the overview of the functional GI disorder. Functional GI disorder, what we mean that the gastrointestinal tract, there are various symptoms associated with a lot of GIT organs like stomach, esophagus, small intestine, and large intestine. But on evaluation with multitude of tests, including endoscopy, colonoscopy, cross-sectional imaging, etc., we could not find out any pathological abnormality present anatomically. This is called as functional GI disorder. So the problem is mostly functional, not anatomical. This is the term that was coined long before, and we call that functional GI disorder. Most prominent functional GI disorder today is irritable bowel syndrome. Also, other symptoms like functional dyspepsia or functional diarrhea or sometimes defecation disorder, all can be classified as functional GI disorder. Next slide, please. So please, next slide. Yeah, okay. Functional GI disorder is classified with is associated with abdominal pain or abdominal discomfort, may be associated with defecation, a change in the bowel habits, or having abnormal defecation. So everything revolves around defecation, abdominal pain, or discomfort. This is a typical definition for irritable bowel syndrome, which has gone various modification, four modification in fact, after 1989, from which it was coined. Next slide, please. The latest classification is called as the Rome criteria. The previous slide. Yeah. So they should have a supportive symptoms of abdominal stool frequency, three or fewer bowel movements per week, abdominal stool forms and or loose or watery stools, urgency or incomplete bowel movement, or passing of mucus or bloating. So this is the latest classification called as the Rome 4 criteria, which is a modification from Rome 1, 2, and 3, which was recently published. The crux of the definition revolves around abdominal discomfort, which replaces by pain, which happens at least once per week for the past 3 months. Next slide, please. Yeah, Rome. Yeah, Rome three. Rome three criteria includes recurrent abdominal pain with 1 day per week for last 3 months, associated with defecation, associated with change in the bowel frequency, or associated with change in the bowel form. Next slide, please. The Rome 4 criteria replace abdominal discomfort with pain, which lasts for at least 1 day per week for the last 3 months, associated with defecation, change in the frequency of stools, or change in the form of stools. Next slide, please. So these are some of the criteria that we use: Manning criteria, Cruise criteria, or recently the Rome 4 criteria. Cruise criteria takes into history, it takes into consideration the patient history, occurrence of flatulence, irregular bowel movements, mixed diarrhea and constipation, pellet like stools or mucus, symptoms more than 2 years, and the global physician assessment like abnormal physical findings, ESR more than 20, hemoglobin less than 12 for females or male less than 14, history of blood in the stools or leukocytosis, rules against the diagnosis of irritable bowel syndrome. Next slide, please. This is a Bristol stool scale which can be used for the patient to describe the consistency of the stool. Next slide, please. So the features of irritable bowel syndrome are abdominal pain, which is associated with defecation, either constipation or diarrhea. Non-chronic symptoms like abdominal discomfort, flatulence can also coexist, and chronicity. Next slide. Yeah. Next slide, please. Subtypes of irritable bowel syndrome can be classified as constipation predominant IBS, diarrheal predominant IBS, mixed IBS, or unsubtyped IBS. The validity of such a classification is still unknown. Next slide, please. This is the relationship of Bristol's stool scale and the subtypes. And the colonic motility is increased, there will be loose stools, and there will be IBS diarrhea type, Bristol stool types of 6 and 7, or unclassified type. And the stool frequency is, the transverse frequency is prolonged, we'll have more hard stools. It will fall into the category of IBS C or IBS mixed type. Next slide, please. Next slide. Bloating usually coincides with the post-meal sensation. It will cause sensation of fullness and a feeling of irritation or flatulence. Next slide. So on ultrasound imaging or X-ray imaging, we find there is a large amount of air pockets present in the small intestine and the large intestine, which causes bloating. And there will be increased in the abdominal volume of people who bloat. Next slide, please. The social impact of IBS is huge. It is the most prevalent GI disorder. There is a 12% visit to primary care physician and 20 to 40% visit to gastroenterologist. This is the seventh most common diagnosis done at the OPD level for any subspecialty and carries significant healthcare costs and disability rates. Next slide, please. The pathophysiology is poorly understood. Multiple mechanisms may be responsible for the symptoms. Factors that are considered are visceral hypersensitivity. There is increased hypersensitivity in the gut mucosa. It causes increased impulses tracking back to the enteric neurons to the precingulate cortex in the prefrontal cortex. Gut-brain axis, which is primarily abnormal. Neurohormonal mechanism where increased amount of serotonin, acetylcholins are released from the nerve endings. Gut flora and dysbiosis. This is what we are going to see. Food intolerance, low-grade inflammation that occurs at the mucosal level, bile acid metabolism abnormalities, and 5-HT3 metabolic alterations and genetic factors. Next slide, please. This is the schema of pathophysiology for IBS. Much of them have been implicated are the local inflammation, local infection causing subtle inflammation, prolonged duration of initial illness, endotoxins, lymphocytosis, ECL, hyperplasia, etc. More common in female gender, so genetic factors might be responsible. Depression, hypochondriasis, so more neural mechanisms may form a part. And adverse life events, so depression, anxiety disorders coexist with IBS. Next slide, please. So there is abnormality in the gut flora, GI infection or alteration in gut microbiota, dysbiosis, abnormal gas handling in the large intestine, diet and food intolerance, which again gives rise to visceral hypersensitivity. Genes may play a part in that. Control of gut function, nutrition intake may be regulated in the hippocampus of the brain, which is little abnormal. Life experiences may cause augmented response of such a kind of findings in the brain, and acute and chronic stressors. There is an alteration in regulation of gut function like motility, sensory secretion, and 5-HT3 metabolism, and there is abnormality in central processing of information, personality trait, anxiety, and depression. Next slide, please. So this is a schema where the genes are implicated. There are genes um, forms a part of the epithelial barrier. CDH1, CDC42, CLDN1, N2, etc. are implicated in the alteration in the epithelial barrier, whereas bacterial translocation happen in case of alteration. Visceral hypersensitivity is promoted by TRPV1, bile acid metabolism by FGFR4, KLP, etc. Immune function alteration primarily brought out by tumor necrosis factor IL-6, IL-10, etc. The gut-brain axis has been altered by the genes like SLC6A4, SCN54, etc., 5H, 5, HTR4, etc., and abnormality in central processing, which involving serotonergic signaling HT3R3A, inflammation-related genes IL-1B, HPA axis dysregulation, CRHR1, catecholamine signaling abnormalities like ADR, A1D, ADRA2B, COMT. So these, when combined with the life experiences and other stressors, give rise to symptoms of IBS. There will be visceral hypersensitivity, there is gastrointestinal dysmotility, there is intestinal permeability, and there is dysregulation of the gastrointestinal immunity and alteration in gut microbiome. Whether this is the cause for the hypersensitivity or hypersensitivity forms a cause for alteration this gut microbiome, we're not able to pinpoint. Next slide, please. This is the response of pain to various functional GI disorders. When the pain threshold, rectal pain threshold is huge, in lower pressures, we'll have IBS and other symptoms. If the pain threshold is very high, then we will have functional constipation and functional diarrhea. And if there is scattered, then we'll have miscellaneous abnormalities. Next slide, please. Next slide. Psychological factors implicated in IBS. Up to 80% of people have abnormal psychological testing. Much of them have major depression. Next slide, please. There is generalized anxiety disorder and panic disorders, phobias, stress and adjustment disorders, and major lifetime events. All can coincide with IBS. Some of these symptoms may go relentlessly for years together, giving rise to recurrent bouts of irritable bowel syndrome. Next slide, please. Next slide. Ah, there is abnormal neurohumoral mechanism like efferent vagal dysregulation, alteration in sympathetic and parasympathetic tone, abnormal viscerosensory or cardiovascular reflexes, and baroreflex abnormalities present in these patients. Next slide. There is exacerbation of hormonal response to CRH, a corticotropic releasing hormone, high plasma renin activity. Next slide, please. Next slide. Pancreatic polypeptide, cholecystokinin, neurotin, gastrin, neurotensin abnormalities, Nitrous oxide levels in myelin neurons are very, very high, and protease activated receptor 2 are also very, very high. 5-HT3 forms a central part in the enteric nervous system. There is dysregulation of 5-HT3 production as well as degradation. The enterochromaffin cells containing 5-HT3 are increased, and there is a peak of 5-HT3 in post-infectious IBS. An abnormal ratio of 5-HT3 IAA is to 5-HT3 levels are reported. Next slide, please. There is abnormality in 5-HT3 pathway also. Next slide. An abnormality in serotonin pathway, which we see 5-HT3 enterochromaffin cells are increased. Also, there is increase in production and decreased degradation of 5-HT3 in the nerve endings. Next slide, please. There is subtle mucosal inflammation. Next slide. Low-grade mucosal inflammation, activation of lymphocytes, mast cells, and pro-inflammatory cytokines. There is altered cellular response with altered release of IL-1B and IL-6. Next slide. Next slide. Yeah. Certain genetic factors are responsible for heightened visceral hypersensitivity and heightened responses to neurohormonal mechanism. Serotonin metabolism abnormality is a known factor. G protein translation ligand receptors like C825T, G and beta 3 are genetically controlled imbalance between pro and anti-inflammatory cytokines are also noted. Next slide. Altered gut flora has been initially seen by Pimentel et al., where 78% of IBS have SIBO. SIBO is small intestinal bacterial growth. Using C14-based D-xylulose and vaginal cultures, there is increased incidence of SIBO in IBS. There is lactose in malabsorption, fructose sorbitol malabsorption present in IBS, which may produce flatulence and diarrheal symptoms. Also, food allergy adds to the complications of IBS in the presence of altered gut flora. Next slide, please. So, is it a chicken or an egg? Whether altered microbiota, SIBO, is a part of IBS, whether it is a causative factor or is an effect of hypermotility or heightened visceral hypersensitivity, we don't know. There is a change in the microbiome pattern, motility of GIT, permeability of enteric barrier, GI immune activation, and visceral sensitivity. Next slide, please. There is a there is an entity called as post-infectious IBS, where Campylobacter, Salmonella, Shigella are more prone for post-infectious IBS. Once the gut is infected with certain kind of bacteria, there is an alteration in the enteronervous system, an alteration in the 5-HT3 metabolism, which may prolong up to 6 months of time, giving rise to IBS-like symptoms. There is increased mucosal enterochromaffin activity, low-grade inflammation persists for more than a year. Next slide, please. This is a food map diet which we give considering the cause for subtle mucosal inflammation in the gut and food allergy that may be responsible for IBS. So we encourage people to eat a lot of lettuce, carrot, cucumber, strawberries, chicken, egg, etc. and avoid garlic, beans, onion, blackberries, watermelon, sausages, avocados, beans, and gluten-based diet. This will reduce the intake of fructose or other oligosaccharides that may precipitate the symptoms of IBS. Next slide, please. Yeah, this is the gut microbiome IBS diet axis. There is a significant IBS symptoms like gas and bacterial fermentation, osmotic overload, dysbiosis, etc. And there is other side, there is a host genetics, gastrointestinal infection, gut microbiome, psychological factors, and diet. When there is an interaction between the symptoms, in the presence of IBS, altered neurohumoral mechanism, and the presence of gut microbiome, there is significant alteration in the pattern of gut microbiome. There is increase in bacteroides, an increase in Enterobacteriaceae, and increase in Pneumoniaceae. These three are the typical bacteria that are found in patients with IBS. And there is good bacteria like bifidobacterium and faecalibacterium are reduced comparatively to the bacteroids and enterobacteriaceae. This kind of shift in the ratios of good and bad bacteria give rise to IBS-like symptoms, which may persist till there is a reversal in the bacterial pattern. Next slide, please. So now we have an integrated model like psychological factors from gut microbiota and psychological factors like external factors, internal factors, and gut-derived factors. Next slide, please. Next slide. Uh, yeah, this is a slide that depicts the pattern in which we detect the abnormality in gut microbiota. Depending on the food, host, and microbiota treatment, we offer them specific individualized treatment for them. So we'll collect the stool sample and we'll run the array of ribosomal pattern for gut microbiota, and we have an array of patterns of microbiota, and we challenge to tweak them with micronutrients, anthropometries, metagenomics, antibiotics, and prebiotics, and with them we tend to um, meddle with the ratio of Rhamnosae and Enterobacteriaceae and um, Bifidobacterial. Next slide, please. These are some of the alarm features which may tell you that we are not dealing with IBS, but with something else like IBD or colonic cancer. Blood in the stools, chronic diarrhea with weight loss, family history of colon cancer, nocturnal symptoms, onset of symptoms after 50 years, dysphagia, recurrent vomiting, short history, travel history to endemic areas of parasitic diseases, and weight loss, and physical examination of abnormal mass, arthritis, dermatitis, anemia, intestinal malabsorption, obstruction, or thyroid dysfunction. Next slide, please. So this is how we diagnose IBS. Patient has chronic symptoms. Next slide. Abnormal pain associated with constipation or diarrhea, or both with or without bloating. Obtain history and perform a physical examination, including medical, surgical, and dietary history, and digital rectal examination. If normal physical examination, no warning signs, apply Rome 4 criteria and make a positive diagnosis of IBS. Next slide, please. Consider limited testing like CBP, CRP, celiac serology, fecal calprotectin, etc., and use Bristol stool scale to identify IBS subtype and initiate treatment based on the predominant symptoms. Next slide. Symptoms are usually Treatment is usually symptomatic. The basic thing is lifestyle changes like high fiber diet, FODMAP diet for people who have food allergy, education and counseling, allaying misconception and clarity. There should be a caregiver and a person to look for anti-anxiety strategies like yoga, meditation, physical therapy, etc. Ask the patient need not be repeated testing one again and again for symptoms because that will cause some amount of um, anxiety in them. So group therapy and community counseling are also important. Next slide. Thank you for patient listening. Thank you. If you have any queries, I'll be happy to answer.
Thank you so much, sir, for giving your valuable time and sharing your precious knowledge on this topic, sir. I definitely think this session knowledge is going to help all the participants during the practice also. As I can see, sir, I have received some questions, sir. If you allow, with all your permission, shall we
Yeah,
take
yeah,
this
yeah,
question?
yeah, yeah.
The first question is from Dr. Chatterjee, and he is asking what methods are available for accessing gut biota composition and activity in patients with IBS, and how might this information guide clinical management?
Yeah. Previously, we don't have sufficient tools to assess the microbiota present in our body. Now that we have ribosomal RNA-based assays to assay the gut microbiome, we can collect a stool sample which is devoid of antimicrobials, antibiotics, or any other drugs. We'll refrain from taking any medicines for 1 week, and then we collect the stool sample and give it to the laboratory. There are several proprietary laboratories available who give a profiling of gut microbiota. Either the genetic footprints are being assessed, or the ribosomal
Sir, you are on mute, sir. Uh, Hello.
ah,
Yeah, shall we move to next question, sir?
ah, ah,
The second question is from Dr. Subramaniam, and he is
ah.
asking, sir, can you discuss the potential role of probiotics, prebiotics, symbiotics, and others microbiota targeted therapies in the management of IBS?
Yeah, probiotics. There are several studies that gives good benefit of probiotic and prebiotics. Prebiotics are simple sugars or complex sugars that forms the basis of growth of probiotics. So when given together, prebiotic and probiotics, probably we can have a good amount of probiotics, a good bacteria into the small intestine. The problem with probiotics and prebiotics is that uh, despite giving the probiotics, there is very little difference in the gut microbiota after 1 month of therapy. This is because most of the probiotics get denatured in the stomach because of the stomach acid. So very few probiotics reach the small intestine, and the environment in the small intestine are also hostile to the new probiotics, so that their growth is also not expected to the level that we administer them. So that is the problem. Two problems is, one is the availability of probiotics into the gut. Second thing, the growth of probiotics is also not to the up to the expectation. But we have several now. The pharmaceutical company has roped in, and we have several type of distribution of this probiotic into the small intestine directly. Either we can do it by endoscopy or with other mechanisms, so that we can directly seed them into the small intestine to have better availability and better growth. Altering the gut microbiota has very good response on the outcome of IBS patients, regardless of probiotics.
Thank you so much, sir, for answering this question. I hope this is will be helpful to all the participants who have joined this session. Sir, as I can see, there is no more questions from the participants, sir. With all your permission, shall we conclude this session for today
Oh,
with all your permission?
sure, Pa. Thank you. Thank you very much.
Thank
Thank
you
you.
so
Thank
much,
you.
sir, for your valuable time, sir. It was
Thank you.
great
We'll
honor to
meet
have
next
you.
time. Yeah.
Yeah, yeah.
Thank you.
Take
Thank you
care,
very
sir,
much.
and till then, take care
Thank
of
you very much.
yourself.
Yeah.
Bye.
Thank you.